I'd like to invite the first person who's giving a presentation on long-term assessment of PC, IOL optic adherence and ND-YAG capsulotomy rate on surface modified IOLs. It's good that we can get to hear about surface modified. I'd used them long time back. Dr. Sridevi Nair and Dr. Tityal. Timer, please. Yeah. Can we have the slides on? Yeah.
So a very good afternoon to all of you. So I'll be speaking on long-term assessment of posterior capsule IL optic adherence and its impact on NDR capsulotomy rate after implantation of a hydrophobic acrylic IL with ozone surface modification. No financial disclosures. So intraocular lens surface modification, various techniques have been described such as surface coating, covalent grafting, plasma treatment and photochemical immobilization. The purpose is to enhance the biocompatibility of the intraocular lenses and lead to a decrease in the incidence of posterior capsular opacification. So an aspheric hydrophobic acrylic IL with posterior surface modification, UV and ozone treatment is based on the mechanism of increased adhesion of fibronectin and lens epithelial cells to the posterior IL surface, which in turn will promote the IL adhesion to the posterior lens capsule and help prevent PCO. So the purpose of our study was to assess the PCIL optic adherence in a surface modified IL and its impact on NDR capsulotomy rate and visual quality. It was a prospective interventional study of 93 eyes with immature senile cataract grade 2 to 4 conducted at Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIIMS, New Delhi. All cases were implanted with hydrophobic acrylic IL with posterior surface ozone treatment after phacoemulsification. Cases with any ocular or systemic comorbidities, extremes of axial length were excluded. The primary outcome measure was a posterior capsule adhesion to the IL optic as assessed using anterior segment optical coherence tomography and the NDR capsulotomy rate. The secondary outcome measures were visual quality as assessed using ray tracing aberrometry. Follow-up was performed on postoperative day 1 year and 2 years. So these are the demographic details of the patient. The mean age was 59.46 plus minus 9.14 years. 93 eyes were implanted, 37 bilateral, 19 unilateral. Intraoperatively, no case had any intraoperative posterior capsular rent or vitreous loss. At 2 years, 94.6% had a corrected distance visual acuity of 20/20 or better. 100% had a corrected distance visual acuity of 20/32 or better. These are the visual representation of the two cases. On the left hand side, you can see a case with complete PC optic adhesion at 2 years and a case with initial smooth PC. So on post-operative day 1, there was 497 microns of fluid between the IL optic and the PC. At 1 year, it increased to 80 microns and at 2 years, complete PC to IL optic adhesion was observed. In the second case, as seen on the right-hand side, on post-operative day 1, there was a wavy configuration of the posterior capsule and 255 microns fluid can be observed. At 1 year, it reduced to 137 microns. At 2 years, the fluid still persisted. 96 microns height of fluid can be observed on anterior segment optical coherence tomography in the visual axis. So on post-operative day 1, 2.9% of our cases had a complete PC optic adhesion. The figure increased to 67.6% at 1 year and 73.5% cases at 2 years. Of note, more than 25% cases at 2 years still had persistent PC optic in adhesion. So this is in contrast to a study by Zhu et al., the only other study I could find with which has evaluated the PC optic adhesion in the visual axis, which evaluated PC optic adhesion in visual axis after phacoemulsification, and they saw that 41.5% cases had PC optic in adhesion on postoperative day 1. 59% had complete adhesion and 7.1% had PC optic in adhesion at 2 months. So at 2 months, nearly 93% of their cases had complete PC optic adhesion. So the contrast may be because they used sheen plug imaging, which is less sensitive than anterior segment optical coherence tomography and may have underestimated the PC optic in adhesion rate. Visual quality at 2 years. So why is all this important? The residual PC optic adhesion positively correlated with the total higher order aberration with a Pearson correlation coefficient of 0.4 and a p-value of 0.03. Strain ratio, modulation transfer function and root mean square total aberrations were significantly better in cases with complete PC optic adhesion. Posterior capsular opacification did develop in 7.5% of our cases at 2 years. So this is a case on the left-hand side of a peripheral PCO with a clear visual axis in a case at 2 years. No PCO was seen in 92.5% of our cases. So coming to the NDR capsulotomy rates, of the 7.5% cases that developed a PCO, 85.7% had persistent PC optic non-adhesion. NDR capsulotomy was needed in 3.2% of cases. All cases requiring laser capsulotomy had persistent PC optic non-adhesion. So NDR was required only in cases that had a persistent PC optic non-adhesion. So to conclude, complete PC optic adhesion is associated with superior visual quality, less posterior capsular opacification, and known ND-YAG laser capsulotomy. Surface modified IOLs are expected to have a higher rates of PC optic adhesion with less PCO. What we saw was that nearly 2/3 of cases at 1 year and 3/4 of cases at 2 years have complete PC optic adhesion. This is the first study to characterize PC optic adhesion using high definition ASOCT in a surface modified hydrophobic acrylic IOL to correlate it with visual quality to study the impact of the adhesion on NDR capsulotomy rates, and it has a long-term follow-up of 2 years, which for cataract is quite a significant follow. Thank you for a patient hearing.
Very nice talk. We allowed one question, so I'll club two questions in one. So one question is, how did you quantify this PCO? Did you follow any score? And two, did you do any anterior capsule polishing during the surgery? Anything was done on any side or not done anything?
So anterior capsular polishing, we did not do. We are not doing in our cases since quite some time. And regarding posterior capsule opacification, we did not quantify it, grade it. Those involving visual axis and not involving visual axis, that was the quantification we used.
I just wanted.
Thank you.
So it's there was a typographical error in the first set of. Please do not mark that. This is the actual set of the marking paper. So we are just. Someone, Pallavi, please collect those marking sheets and tear it. So there was an error, a typographical error, which we have corrected, and we are redistributing that. So, Dr. Haldipurkar sir, since you've been in this first paper, so please come up on stage and you can also be the judge for it. So all papers 6 minutes, and we will follow the order that is there. So I'll quickly read out the order. Dr. Deepak Mishra goes next. Dr. Prasanna Venkatesh Ramesh goes next. After that is Dr. Neetu Daniel. Oh, sorry. No. Oh, sorry, I'm sorry. No, I'm very sorry, yes. Dr. Manpreet Kaur. After that, Dr. Hirika Gosalia. Then is Dr. Jitendra Jethani. After that is Siddharth Narendran. After that is Thirumalesh. After that is Dr. Livia. After that, followed by Dr. Siddharth Dikshit, then Dr. Deepak Mishra, Dr. Prasanna Venkatesh, Dr. Seema Das, Dr. Neetu Daniel, Dr. Shaifali Chachar, Dr. Arvind Kumar Maurya, Dr. Pooja Khamar, Dr. Shweta, Dr. Prithvi, Dr. Sangeet Mittal, Dr. Poorna Chandra. So Dr. Livia's presenting author is Dr. Vanati. She has presented in the first round, and also in this round she is the presenting author. And there was a mail from her, from the authors, and we have accepted that. So she is the presenting author for the preliminary as well as for the final. Same.
So I think we'll move on to the next paper. Smart Scope Kit, a portable eye hospital for screening in outreach camps. Dr. Hirika?
Yeah, so good afternoon, everyone. I have no conflicts of interest, no financial interest. Today I'll be speaking about SmartScope Kit, which is a portable eye hospital for screening in outreach programs. I'm Dr. Hirika Gosalia, a postgraduate resident at Arvind Eye Hospital. It's a tertiary eye care center catering to a large population with a high quality treatment at affordable rates. So, usually conventional instruments are quite difficult to be used because of bulkiness and risk to damage at outreach programs. And hence, when we go to camps, we use torchlight examination for anterior segment and we use direct ophthalmoscope for the posterior segment. That's when I thought that maybe we are missing out on a lot of findings otherwise when we are just screening with these instruments. And we came up with the Smart Scope kit, which is a comprehensive eye kit for every ophthalmologist, especially in outreach camps. So we measured the visual acuity with the Eye Handbook, which is a free download app, wherein we can measure the vision test, the Amslers, the color vision test. Then we also added the pinhole occluder, the plus 10 diopter lenses, the trial frame, and the trial set. In investigations of the systemic illness, we included the pulse oximeter, the BP machine, the glucometer, and many investigations for the orbit and the corneal pathologies. In the anterior segment, mainly, we included many innovative, easy tools like the iVerter, which was used for the eversions of the lid to remove the corneal foreign body, which is a good alternative to the universal eye speculum. We used the ASPE, which is the anterior segment photography intraocular lens, wherein we attached an intraocular lens which was a great alternative to the slit lamp examination. So we attached it behind the smartphone against the smartphone camera to capture good resolution, highly magnified images, and we used a flashlight for illumination, and we could detect many great findings for referral, especially like you can see in the next slide, wherein you can see all the pathologies captured from corneal to cataract to iris coloboma, PXF, ASCC to neovascular glaucoma to hydrops to OSSN to even pterygium, subluxated lens, and an eye syndrome. We measure the IOP with the Schiot's tonometry. In cases of torchlight examination showing a doubtful narrow angle, we did a gonio ASPE, which is just adding a 8 diopter lens instead of the 15 diopter lens. And then in cases of ulcer suspect, we use the IOL scope, which is an alternative to the compound microscope. We use 4 30 diopter lenses heaped upon each other, and then against the lens smartphone camera we could detect one case with fungal hyphae and another case with a foreign body sensation showing a sheep botfly larvae. So, and the next was the Scooby, which was a smartphone co-aided cobalt blue photography, wherein with the intraocular lens, we also added a cobalt blue filter. So, this was mainly for the corneal pathologies, wherein we saw many epithelial defect, we saw PEs, we even saw filamentary keratitis, dendritic ulcer. So, these comprised all the instruments for the anterior segment examination of the patient. Next, coming to the posterior segment examination, we did the trash to treasure at cam, the T3R, wherein we used a sanitizer bottle and we cut out one end of the bottle, and here we attached a 20 diopter lens for the examination of the fundus. The other lens, other side was attached with a adapter, wherein we attached a smartphone and to capture videos or images of the retina. So here were a few findings that we found: the retinal detachment, macular hole, and many diabetic retinopathy patients. So this was a smart scope kit. So mainly we did this across. We normally go for camps in the Tamil Nadu, Kerala, and Karnataka, and we did it for 4,741 patients in 26 camps, wherein we found cataract in 83% and non-cataract in other cases. And then cataract we found immature cases the most, glaucoma we found PACS the most, and then retina we found diabetic retinopathy the most, orbit we found chalazion, and neurophthal we found optic neuropathy. So out of those 4,741 patients, we referred cases for cataract as 1,220 and other non-cataract 254 cases, out of which treated were 937 for cataract and non-cataract around 99 cases. So SmartScope kit was a great alternative to the existing gold standard instruments, especially ASPE being for slit lamp, Scooby being for this blue filter, ILScope being for the compound microscope, and Trasher RedCam for the fundus camera, and also the eye handbook for the Snellen's chart. We also use the iVerter and Gonio ASPE for one for the lid eversion. So it is an effective screening method of patients in outreach camps from anterior to the posterior pathologies, can avoid misdiagnosis and missed diagnosis. It's a do-it-yourself, comprehensive, cost-effective, innovative kit which comprises all essential instruments, and it helps in spot diagnosis, earlier treatment, and helps in better prognosis of the pathology, helps to explain the importance of treatment and referral to the base hospital. I would like to conclude by saying this is a new age, innovative, effective screening tool, especially in places like outreach camps wherein you're devoid of many important investigations. Thank you.
Very
You-
nice.
Okay. You asked, you saw the fungus in the using the optics of the lens. Can you, could you see that bacteria or?
No, like of bacteria, we could only, mainly for fungal spores, it is quite helpful.
Yeah.
Bacteria, it was difficult, but for fungal
Yeah,
spores, it
sure.
was very helpful for us.
It is a very nice innovation.
Thank you,
Against
sir.
what background you saw this fungus?
Yes.
Against what background?
We did only the KOH mount, so we had the slides along with us in the kit.
Can this be used in a hospital setting also?
It can be used. I'm just showing. We are actually doing a. We have used it for many other studies. I'm just showing the use of it in the outreach camp.
You want to show that it is non-inferior to this slit lamp that we use.
It's a good alternative, is what I would like to say.
Thank you.
Thank you, sir.
May I call upon Dr. Jitendra Jethani? He'll be speaking.
Good afternoon, everybody. Yeah, we all know that myopia progression is on rise, and we have now understood that the key factors to myopia progression is near work, which causes peripheral hyperopic defocus, and alternate dopamine release. There is huge literature already available on atropine. We all know that low concentration atropine, that is 0.01%, halts or slows down the progression of myopia. But there are non-responders to low concentration atropine, depending on which study we are seeing. There are almost 20 to 50% of children who do not respond to low concentration atropine. A typical non-responder will be classified as minus 0.5 diopter increase in refraction per year, or an increase of 0.2 millimeter per year is dubbed as myopic progression non-responder. With this background, we decided to assess the effect of DIMS or myosmart lenses or peripheral myopic defocus lenses, which causes a peripheral defocus, as an addition to the existing low concentration atropine eye drops on myopic progression in children who were not responding to low concentration atropine. Now, we had around 10 children who were already on atropine and were not responding to atropine since last 1 year. It was a non-randomized single-arm interventional study with the glass power was increasing more than 0.5 diopter per year. And the primary endpoint was to see the progression at the end of 1 year. At the end of 1 year, the mean spherical equivalent was minus 3.9 diopters. Pre-atropine progression, which means that 2 years back, these particular patients were progressing at a speed of minus 0.76 diopters per year. Pre-DIMS, which means after giving atropine, the progression reduced to 0.68, and post-DIMS, the progression reduced to 0.39. But in 8 patients, it was 0.24, and 2 patients, despite using DIMS, were non-responders to DIMS. Although their progression slowed down, they were not fitting into the classical definition of reducing the progression to less than 0.5 diopters. So we all now know that low concentration atropine drops are used to reduce or slow down the myopic progression. Non-responders are there. So one of the alternatives to non-responders is to increase the frequency. Another is to add another therapy of reducing the progression, which is peripheral defocus lenses. A classic paper in 2009 was published by Earl Smith, which basically has led to change of all these therapies into myopic progression, which says that the peripheral retina were actually responsible for eye growth. This was an experimental study which was published in 2009, done on macaque monkeys. Now, DIMS is a lens which causes myopic defocus instead of the standard hyperopic defocus. These are few studies which have been done outside India. There are no studies in Indian eyes. The advantages are that DIMS glasses do slow down the progression. There is no rebound effect, but one of the major problems with these studies is the selection bias. The peripheral refraction of a myope is known to be hyperopic. We know this from Western literature. One of the studies done, only one study done from India is from LVP, where they showed that only temporal retina showed hyperopic defocus in Indian eyes and not the nasal retina. There was a wonderful article in 2022 by Kamak et al. Which said that there is a possibility that we can use DIMS, can be added as an adjunct to LCA, and it is safe to use DIMS. We did use DIMS. We used it before they published this. So we did a peripheral refraction in our patients with our own innovative device. The central refraction, you can see the mean was minus 3.9 diopters with temporal 22 degree and nasal 22 degrees showing hyperopic defocus. Our study is unique, where glasses were prescribed on the top of low concentration atropine eye drops. No such study has been done. This was in conjugation with, we did not stop the low concentration eye drops, so it opens up new possibilities for treatment of patients who do not respond to low concentration atropine eye drops. DIMS lenses, we have a follow-up of 1 year, so it does show some initial promise in reducing the progression of myopia in children not responding to low concentration atropine eye drops when given in conjunction with low concentration atropine eye drops. Thank you so much for the attention.
Very nice presentation. So you have used MyoSpecs, right?
We have used MyoSmart
yeah,
glasses.
those MyoSmart lenses. I want to know what is the range of myopia that you have been used? What is the maximum range of myopia in which patients?
So MyoSmart lenses come at a maximum range of 10 diopters. 4 diopters cylindrical and 10 diopters spherical, but it is additive. So if you have a minus 6 diopter lens and a minus 4 diopter cylinder, then that is the maximum that you can make. Or you can make a lens of minus 9 diopters without any cylindrical. So the maximum lens we can get is 10 diopters.
Okay, and along with the lenses, have you advised something else like?
So they were already on atropine. Atropine was continued. Because if we stop atropine, we are at a risk of getting a rebound of atropine, and we won't be able to assess whether it is the DIMS which is not working or it is the rebound of atropine. So we started atropine, and then when they were not responding, we added DIMS. So that is where it is quite unique that this has not been tried anywhere.
Thank you. Very nice.
Thank you so much.
Next, we have a paper by Dr. Siddharth Narendran. It is on nucleic acid extraction, free CRISPR, CAS12A based diagnostic platform for fungal keratitis.
Thank you. So good afternoon. My talk is on the development of a novel first-in-class CRISPR-based diagnostic platform for point-of-care diagnosis of fungal keratitis. Despite afflicting more than 1 billion people and causing more than 1.5 million deaths annually, fungal infections unfortunately remain a pernicious neglect. This is best exemplified by the misdiagnosis rate of fungal infections across various organ systems. Hence, there's a huge unmet need to improve fungal diagnostics. So for any new diagnostic modality, it's important to understand the unmet need for that particular condition. For fungal keratitis, there's a huge unmet need to diagnose fungal keratitis at the primary healthcare level. So our purpose was to develop a rapid, non-invasive, cost-effective point-of-care test to diagnose fungal keratitis using CRISPR, which we have termed RIDMIC, which stands for Rapid Identification of Mycosis using CRISPR. So before this, a brief introduction to CRISPR. In one line, they are the antibody equivalents of prokaryotes. So when we as eukaryotes come across a virus, we recognize their proteins and produce specific antibodies against them. While given the primitive state of the prokaryote immune system, they rather recognize foreign sequences and engineer Cas enzymes to identify and cleave these nucleotide sequences. So this is the workflow of the assay. It includes 4 processes. First is the DNA extraction, followed by the isothermal amplification, which amplifies the target fungal DNA if present, followed by the CRISPR reaction, which in the presence of the amplified fungal DNA cleaves the fluorescent reporter, which is visualized as fluorescence. So because our aim was to develop this both as a point of care test and as an alternative to PCR, we included 2 readouts. First is the qualitative binary interpretation, which makes it ideal for point of care testing, and the quantitative readout, which makes it easy to predict fungal load in tertiary facilities. So the first step was to test the specificity of the assay. As seen here, a positive test was seen with all tested fungal DNA, but not with bacterial or human DNA. Then we tested the analytical sensitivity of the assay. This was around 13 to 16 genome copies for these common fungus, which was better than pan-fungal PCR. So then we tested the clinical validity of this assay. So the sensitivity and specificity of rhythmic was superior to PCR. But however, to assess its applicability as a point of care test, we first dissected the process into 4 distinct steps: DNA extraction, isothermal amplification, CRISPR reaction, and visual detection, and assessed it against WHO's assured criteria for an ideal point of care test. When we did this, we realized the DNA extraction step was accounting for 56% of the cost, 45% of the time, required the most expertise, and required complicated equipment, and was the only step which was dependent on electricity. So we wanted to bypass this and see if we could develop a assay without compromising on the sensitivity and the specificity. So we have precedents for this. We know that direct PCR without nucleic acid extraction works as well as traditional PCR, but greatly improving its clinical utility. So first, we looked at the concordance between these 2 methods. So the extraction-based methods requires lysis and followed by DNA extraction, and the whole process takes 25 minutes. While here in the extraction-free method, a shimmer strip is placed on the ulcer and directly subjected to the rhythmic assay. So the concordance between these 2 was 100%. The next step we saw was what is the time to achieve a positive diagnosis. Here we measured the fluorescence using a spectrophotometer, and we saw the time taken to cross the threshold. So there is no significant difference: 23 minutes with an extraction based method, while 25 minutes with an extraction free method. So this video shows the workflow of the assay. Shimmer strip is placed on the cornea, and then followed by the RPA reaction, which happens at 37 degrees Celsius for 30 minutes. It's important to note that the pipetting is the only expertise which is required, and heat block is the only equipment which is needed, which can function without electricity. This is followed by the CRISPR reaction, which happens at 10 minutes, followed by the visualization. So after this phase, we went on to again clinically validate this assay in 146 patients with smear positive microbial keratitis. The operators of the rhythmic assay were blinded to the results of other conventional mycological methods. So being a nucleic acid detection modality, we tested it first against the PCR. The sensitivity of rhythmic was 94.5% better than PCR, and the specificity was 84.62%, again better than PCR. So the concordance of rhythmic with culture was 76%, which was similar to the concordance rate between KOH and culture, and the concordance between KOH and rhythmic was 94%. So this shows the mycological spectrum of the species detected by the rhythmic assay in clinical specimens. It was able to detect Aspergillus, Fusarium, Curvularia, Candida, Xerohilum, Bipolarus, Cylindrocarpon, and even Dementicious fungi. We did not come across a species which was not detected with this assay. So now again coming back to the assured criteria. So now we compared how it aligns with WHO's criteria for a point of care test. So rhythmic is the only assay which can be performed without electricity. It takes less than 60 minutes. It's only 45 minutes the mean time. And the sensitivity and specificity is comparable to PCR. At this point, it costs 350 rupees per sample, but there's no batch effect like a PCR. Each sample is going to cost the same, which will come down with mass production. So to conclude, this is the first CRISPR-based system reported for the broad range diagnosis of fungal infections in any organ system. It is the first CRISPR-based system for the diagnosis of any ophthalmic condition. DNA extraction-free rhythmic reduces the time and cost by half and is not dependent on complicated equipment or electricity. It is a point-of-care test that can be applied at the primary healthcare level. We are now in the process of multiplexing it for species differentiation and also for the identification of antimicrobial resistance genes. Thank you.
I just wanted to find out that you do that normal PCR, that
Yes,
you get that broad 16S RNA region. but that detects all types of fungus.
Yes, sir.
But do you miss by this procedure some fungus
No,
species?
so we did 3 times, sir. In silico testing, we tested 20 pathogenic fungus, which detected. On the lab, we tested 9, it detected. And in the clinical specimens, in the 146, we have not come across any species which was not detected by the rhythmic assay.
Wonderful.
Thank you.
Thank you.
Thank you.
Invite the next speaker, who's going to tell us about a novel molecular mediated inhibition of ICAM as a target for diabetic vascular leakage, preclinical trial, Dr. Trilu Malesh.
Thank you. We all know that we are in the middle of a diabetic epidemic, and I'll be talking about LFA1 antagonist, which kind of blocks the ICAM mediated effects, and how is it compared to something like ranibizumab that we already use. I have no financial disclosures. We all know that diabetic retinopathy has multiple pathways through which the disease progresses, but we only target VEGF. Although we have steroids which can block everything, but it can cause side effects like cataract and glaucoma. That's what makes it something that we look down upon it. But however, if there are certain specific markers like ICAM which can produce effects which are very similar to VEGF, it can be a great target. Now, what is ICAM? ICAM is a pro-inflammatory master regulator cytokine. This is going to act upon an LFA1 receptor, which is the blue thing that you can see, and ICAM is the small green thing. So this thing will cause the leakage in the cells, and it also kind of influences the adhesion of circulating immune cells, and it contributes to immune cell migration. So if we remember, leukostasis is the earliest phenomenon that one encounters in diabetic retinopathy. Now, during our discovery phase, why we kind of narrowed down to ICAM was that we did an aqueous humor analysis of many patients, and we were looking at ICAM consistently, and we found that in patients who are having diabetes, diabetic macular edema, and who are under treatment, we saw that all the VEGF went up, and with treatment it kind of fluctuated, but every single time the patient had diabetic macular edema, both in treatment naive and in recurrent cases, ICAM was found to be higher, and it kept on going up with every treatment recurrence, which means that this probably is something which is very important in treatment of DME. So our purpose was to investigate this and compare with ranibizumab. Now, to prove the mechanistic phase, what we did was we took endothelial cells, which were derived from human umbilical vein in a culture plate, and we also took the ARPE cells. Why we took these two are because these two are the blood retinal barrier. The RPE is the outer blood retinal barrier, and endothelial cells are the junction, the ones which keep the blood vessels from leaking. So when we gave these two cells stress in the form of inflammation by adding TNF-alpha or producing hypoxia, or when added sugar to it, producing hyperglycemic environments, we saw that the first thing that it did was it produced ICAM. So that was proved by the mRNA expression and the secreted protein levels that we measured in the supernatant, which means that, okay, at the cellular level, this molecule is also present. Now, the next thing we did was we looked at whether the secretion of ICAM gets influenced by VEGF. So when we added VEGF to the culture plate, it did not produce increase in soluble ICAM. But when we added TNF-alpha, the secreted ICAM levels went up. And when we added anti-VEGF, the secreted level of ICAM was unaltered. It was altered very minimally, which means that ICAM can actually, it's something which is independent of VEGF mechanism. It is present before it, and it does not get altered with it. That's why we saw that in recurrent cases, the ICAM levels were high. Now, based on this, we did another experiment where we put the raw ICAM, and it produced very similar VEGF-like effects, which means that it is a molecule which is independent of VEGF, but it also can induce tube formation in endothelial cells. Now, I'm talking about a soluble levels in the aqueous, but is the ICAM present in the diseased tissue? You can see that I have shown that the ICAM is present, and is the LFA1 receptor present? So I will show you that in the third part of the slide, that the LFA1 receptor is also present. So I have shown a molecule which kind of influences DR. I have shown that it is there in the aqueous secreted samples. I have also shown that it is present. Its receptor is also found in the diseased tissue. So based on this, we started an in vivo study where we took sprawling dolly rats, and we gave them diabetes by giving streptozotocin in its interperitoneal cavity by 65 milligram per kg body weight, and then we waited for 12 weeks. After you wait for 12 weeks, you know that the rats have developed diabetic retinopathy. They also develop cataract. That's why we cannot image them. So we had to sacrifice them. So before once we confirmed that one of the cages of the rats had diabetic retinopathy, we sacrificed that rat and examined it. And the rest of them were injected with both LFA1 antagonist in one group, and the other group was given ranibizumab. Now, before we sacrificed this set of rats, we injected fitsidextran in its tail vein, and we read the vascular readouts. So why fitsidextran was injected was fitsidextran is a fluorescein-like dye. So we sacrificed them and we observed within 2 hours. So this is a functional readout that we were looking at, what happens to the vascular leakage. So you can see that in a non-diabetic rat, the endothelial integrity is maintained very well. There is not much leakage. But when we induced diabetes by injecting streptozotocin, there is definitive formation of microaneurysms and there was leakage as well. Now, when we gave anti-VEGF, this kind of leakage which was there was inhibited. So it means that anti-VEGF was working just like it works in humans. But in the LFA group also, you can see that the leakage was prevented. So was also the leakage from the microaneurysms as well. So which means that this can kind of be a novel molecule which can be used in human subjects at one point of time. Now I'll compare that with the human this thing, and you can see it is very similar. So based on this, we did a ICAM overexpression in the second experiment. This time we took mice because the rats develop cataract, the mice don't. So you can see that when we did an ICAM overexpression, there was microaneurysm formation, which is very similar what happens in DR. So ICAM does have a role, and we showed that it can work. So anti-VEGF and ICAM produce similar type of effects. RWJ can be a definitive target which can help in treating DME, and more robust animal data is required for going for the next stage of the trial. Thank you very much.
Are there any other studies which have shown ICAM to be overexpressed in diabetic retinopathy?
Yes, sir. If you can, if you see the molecular assay of the aqueous, many authors have reported that ICAM is found in the soluble as a soluble factor in the aqueous.
Has antibody to ICAM developed?
No, sir. This is the novel one that we have developed, sir.
Okay. And the rat experiment that you did, they developed diabetic retinopathy in what period of time?
Sir, SD-rat is a very standard model for studying diabetic retinopathy. The sprawling dolly rat usually takes about 12 weeks for development of diabetic retinopathy. But the thing is, why we went for a wet mount? In the mice, I showed you a fluorescein angiogram. That was when the mice was alive. Sprawling dolly rats, once you induce diabetes, they develop cataract. So they are not amenable for doing fluorescein angiogram. So we have to inject a FITC in its tail vein and sacrifice it and then examine on a wet mount. However, in the mice model that we developed, the wild mice don't tend to develop cataract, so they are amenable for doing a fluorescein angiogram. And we captured that when you hyperexpress the ICAM and do not induce diabetes as well, that can produce microaneurysms. And microaneurysm is a signature of diabetic retinopathy, which means that it definitely has a role right from the beginning. It also has a role when the disease is progressing and when it becomes resistant to treatment.
Right. Thank you.
Thank you, sir.
I've been waiting. Thank you. Invite the next speaker, Dr. Vanati, on topical human immunoglobulin as an adjuvant therapy in refractory dry eye disease.
Topical human immunoglobulin as adjunct therapy in dry eye disease. Have no financial interests. The background work for this study is based on the fact that the cellular processes in the ocular surface which are involved in the pathology of dry eye disease have now been attributed to the presence of anti-citrullinated autoantibodies on the ocular surface, which increase the phenomenon of netosis, which is probably contributory to the refractory dry eye disease, which is present in these cases which do not respond to conventional dry eye therapy here. The review of literature points to the presence of netosis, which contributes to refractory dry eye disease and has been found to be responding to targeted dry eye therapy in such cases. Paucity of literature on the response of chronic dry eye disease to ocular surface human immunoglobulin therapy was a lacunae in literature which we wanted to evaluate, and the rationale for the study is that chronic ocular surface inflammation remains refractory to even topical immunomodulators like steroids, cyclosporin and tacrolimus, and hence we look at targeted therapy in dry eye disease to increase the success rate in the management of these cases. The aim of this study was to evaluate the role of of topical human immunoglobulin IgG eye drops, 4 milligrams per ml, as adjunct therapy in the eyes with moderate to severe dry eye disease. This is a prospective longitudinal interventional study done at our center during the period ranging from April 21 to July 22. The sample size comprised of chronic dry eye disease patients of moderate to dry eye severity with a minimum of 30 eyes as cases and 30 eyes as controls evaluated over a period of 6 months. The inclusion and exclusion criteria are as described in this here. The study commenced after obtaining Institute Ethics clearance, and CTRI registration was also obtained. Informed consent was taken from all study participants here. The flowchart of our study is as depicted. We looked at a minimum of 60 patients, 30 cases and 30 controls with moderate to severe dry eye disease evaluated for ocular surface evaluation tests as the OSDI scores, the TBUT, the Schirmer's, hyperemia scores, the corneal and conjunctival staining scores were evaluated. We also developed a treatment grading score to give an objective score to treatment improvement when we used ocular surface immunoglobulin therapy. Topical immunoglobulin IgG drops was reconstituted from the commercially available intravenous IgG formulations here. Statistical analysis and appropriate tests was applied to our data here. Demographic detail analysis shows that the cases and controls group was an age and gender matched group here. And looking at all the study parameters of ocular surface evaluation, namely the DUCE2 scores, the OSDI, Schirmer, staining scores, and hyperemia scores, all showed a statistically significant improvement over the period of study evaluated at 3 months and 6 months vis-a-vis that seen in the controls of our patients here. These are all box whiskers plots depicting the distribution of the study characteristics over the study period time of all the study parameters which are being evaluated here, and all these go on to show a statistically significant improvement in the study parameters over the period of time here. These are certain representative photographs of the study participants showing improvement in their treatment when we used IVIG as an adjunct therapy in these cases here. Again, evaluating the change in treatment parameters, looking at the change in steroid dependency over the follow-up period, looking at the change in the frequency of application of lubricants over the period, all showed statistically significant improvements during the course of the study in our study subjects here. This table also shows the statistical significant importance both at 3 and 6 months vis-a-vis the comparison to our control group. Evaluating change in the median change also showed a good improvement in these cases here. So to discuss our study there is a good improvement on ocular surface evaluation parameters over adjunct therapy on ocular surface immunoglobulin therapy. But what we did find, a minimum of 3 months therapy is required to achieve and to see an improvement in all the study parameters here. No correlation between the study severity and the steroid dependency in these patients here. Success rate determined based on our data showed an improvement in ocular surface evaluation in 75% of our cases. Treatment scores improved in again 74.9%, and the symptom evaluation OSDI improvement was seen again in 75% of our cases here. 4 cases we did have concerns. One was an ALL patient who expired due to systemic complications. One was a myelodysplastic syndrome patient who developed an anterior uveitis which was not related to the therapy here. One patient of ALL had poor compliance and developed progressive cicatrizing conjunctivitis, and one AML patient developed microbial keratitis not related to the medication because of poor follow-up here. Conclusion: adjunct therapy with topical ocular surface immunoglobulin IgG therapy has a significant role in moderate and severe chronic dry eye disease compared to conventional therapy in terms of improvement in symptomatology and reducing disease severity and ocular surface staining scores here. Limitation: a larger sample size would perhaps further enhance our result accuracies, and again a randomized study would probably also give us a better understanding here. Recommendations is that ocular surface immunoglobulin therapy can be considered as an adjunct therapy to reduce chronic refractory inflammation on dry eye disease cases. These are my reference. I would like to acknowledge the contribution of all the co-investigators in this particular study here. Thank you for your patient listening.
Yeah, you can ask.
Very nice presentation. You have taken all very important points like OSDI scoring and all the different standings, but have you taken any inflammatory parameters like MMP9 or even the osmolarity in those dry eye patients?
So that would be one of the limitations here. But again, when you're looking at evaluating inflammatory mediator scores, the limiting factors is that a study sample of 30 cases is not going to be enough, because what you're looking at is nano ml of inflammatory mediators, and your study sample needs to be really large and huge if you're going to look at statistical significance. Again, all studies show that looking at inflammatory mediators is largely non-specific, because you cannot pinpoint a particular biomarker as an inflammatory mediator which will show improvement when you're giving a therapy.
Thank you.
Invite the next speaker who will tell us about shallow EC and a deep problem, acute intraoperative aqueous misdirection and phacoemulsification. Siddharth Dixit.
Thank you. And I wish a very good afternoon to the esteemed judges and all the friends here. I'll be presenting a short series of patients who underwent IZHV as a treatment for acute intraoperative aqueous misdirection, which I'll be referring to as acute misdirection, at the LV Prasad Eye Institute during a 5-year period. This institutional review board approved retrospective study looked at patients who had acute misdirection during phacoemulsification with characteristic signs like acute shallowing of anterior chamber with iris prolapse, inability to inject viscoelastic, and forward movement of the lens iris diaphragm, with a normal fundus glow and external factors being ruled out. The patients who underwent IZHV were included only if they had a follow-up of 1 month. All the ocular findings and investigational findings were documented. Special attention was paid to find out the step at which this event started occurring and the anterior chamber depth on follow-up. The external factors which can appear suddenly during a surgery are basically a tight speculum or the patient who starts straining because of cough, sneezing, or a full bladder. These have to be ruled out after speaking to the patient. Any fundus with suprachoroidal or choroidal detachment is not likely to have a good fundus glow. So a good glow basically rules that out. We included 7 patients, 4 of whom underwent combined cataract and trabeculectomy. 5 patients had angle closure. Most of these patients were having high pressure and were on multiple medications. 1 patient had a short axial length and 1 was a high myope. And some of these had a very slightly thicker lens than normal population. This is an example of one such patient who was undergoing a routine phacoemulsification. Well, it was routine only till I started doing the irrigation aspiration. And during IA, I found that the anterior chamber was shallowing and a floater from mid-vitreous started coming towards the posterior capsule. It became difficult to go ahead with this surgery as the PC was bulging even ahead of the rhexis margin, and it was becoming more and more difficult to proceed without a risk. Any attempts to reposit the iris or inject the viscoelastic into the eye to deepen it failed, and all the viscoelastic was coming out of the eye. After speaking to the patient and ruling out the external factors and looking at the good fundus glow with a hard globe, and a diagnosis of acute intraoperative misdirection was made. And we could not proceed even with intraocular lens placement, which I thought might just push the PC back. At this stage, I proceeded with what is considered the gold standard treatment for chronic misdirection, IZHV. Alcon 26 gauge vitrector was used to create a IPI at a site away from the incision. And if you look carefully, you will notice a pupillary snap at the point where the anterior vitreous face is punctured. And at this point of time, the game changed and I could proceed with the surgery like in a normal phacoemulsification. It's very important to note that there are certain parameters which are different from a normal vitrectomy, like the very low cut rate which you should use for an iridectomy and the IA cut mode. whereas for zonulocapsulectomy and vitrectomy use almost normal parameters like a normal vitrectomy. Most of these patients had this event occurring when there was hypotony and shallowing of the anterior chamber, which led to further shallowing. The intraocular pressures in these patients at the last follow-up remained controlled, though some of them needed multiple medications. Visual acuity in 2 patients were suboptimal, and 1 patient had a vascular occlusion, and 1 patient underwent Nd:YAG hyalodotomy for fibrin membrane at the site of PI. It's very important that in these patients we use a combination of mydriatic cycloplegic by using atropine and tropicamide phenylephrine combination for a prolonged period and gradually reduce the frequency and the number of drugs over a period of 2 to 4 week blocks and not suddenly stop them. The confusion in management of aqueous misdirection is also reflected in the nomenclature. While a recent series mentioned anterior approach IZHV as the procedure of choice for chronic misdirection which is not responding to laser and medical therapy, they went on to recommend pars plana decompression with either a needle, which is similar to the Chandler's procedure proposed more than 50 years back, or a pars plana vitrectomy. But in the diagram that they published, they recommended an anterior approach. I think it's a time for a paradigm change. It is a small series with short follow-up, and this happens to be the first series on anterior approach IZHV for acute misdirection. This is also the first detailed description of the technique of IZHV. We did not have any recurrence in any of these patients for this rare disease. I believe a large part of it depends on the atropine and phenylephrine tropicamide combination that we used postoperatively. Thank you.
It was a very nice paper. 2 things, I have 2 comments to make. Number 1 is that sometimes in this kind of situation, the AC may be so shallow that no instrument goes in. If you try to push it in, it is going to traumatize the proximal iris tissue and the cornea. So in that case, perhaps, the pars plana vitrectomy approach will save the day. And second thing, how to explain the vascular occlusion episode that you experienced?
Thank you for the comment and the question. Fortunately, we were not in that bad a situation. The vascular occlusion probably happened during the 6-week period when the patient was waiting for surgery and had macular edema even on post-op day 1. So even if that had happened during the event, we would not have macular edema right away from the day 1, which probably means that sometime during the time when she was controlling her hypertension and diabetes and waiting for surgery, those systemic causes precipitated the vascular occlusion.
Thank you.
Thank you so much.
Invite the next speaker, Dr. Deepak Mishra, a study on problems faced by residents in learning and performing external dacryocysto-rhinostomy.
Respected judges and dear friends, mine is very simple study to done on what are the problems faced by a resident during DCR. There is no financial interest. As we all know that DCR is the prominent cause of ocular morbidity in India and almost the most common cause for the EP4A. External DCR remains a gold standard treatment for all of the time since more than 100 of years. Everyone is doing this, and the success rate of DCR varies from 82 to 99% in various studies and there. But why we plan this study is very much important. Most important is that when we search the PubMed literature and other thing, then there is no such big studies or any studies who have find out these surgical outcomes or the complications reported by only the trainee, not by the experts. And second one is each and every places, even our teachers can guide. If you do lot of DCRs or good surgery, huge number of surgery, your results will be better, complications will be less. But what is the number? How much number is needed for a PG curriculum or anywhere to say that if anyone can do such a number of cases or such a number of things, he or she have some better things. Like in our residency, we are told by our teachers at least do 15 suturing on gloves, then come to us for that. Similarly, this study is planned. If we got any number or significant number in future, then we can recommend that at least in the residency training program, we have such a number of cases given to first year, second year, or third year. With this aim, we started this study. And the objective I've already mentioned. It was a cross-sectional observational study done in the duration of almost 1 year, October 21 to September 22. We have taken the institute ethical clearance for this. Inclusion criteria almost standard. All the patient attending our OPD and having indications for the DCR surgery. We excluded the complicated cases, failed DCRs or the another DCRs. For that, only the primary DCRs were given. And a questionnaires we prepared for all the residents, which we have given. We have quantified 7-8 major steps in the DCR surgery process, which step is important and which we can go. Assessment, all the patients were assessed as per the guidelines of our own hospital, and the DCR protocol is being followed. All the steps of the surgical steps, whatever is the things needed, prescribed in the traditional books, and when all done into the same way. There is no change in it. The data we got analyzed by the SPSS software, and p-value is considered as to find out any significant improvement is there or not. So I'm coming to my results and observation. Total 35 responses we obtained from the junior residents, 30 from junior resident and 5 from our senior resident. All residents belong to the age group of 25 to 34, and 11 were male and rest female. Among the 30 junior residents, 10 were from the first year, 10 second year, and 10 third year, and 5 SRs. We clubbed them, these 5 SRs, they are just completed the third year, into the third group to find out the responses. And here is this response. We have given almost 10 to 15 surgeries in each groups, so that the first year should get 20 surgeries, 15 to 20, then third in the second years they will become 30 to 70, and in the third year become 80 to 120 surgeries, so that we know how many surgeries they perform to reduce the rate. This is the problem, most common problems faced by the all residents. They are saying one problem is there. In the problem of the first year, we have seen the planning, angular vein management, and suturing. Second year have different type of problems. Are they all these the problems they are facing? And here we quantify each and every problem. Means in the first year is having incision, angular vein management, and nasal packing problem, which is almost obsolete after in the second year or third year residents. Means after doing 15 to 20 surgeries. But the problems with bone punch and nasal mucosa still persist in the second year. Means after 30 surgery or 25 surgery, these problems will reduce, because none of the third year have such type of problems. But again, I am saying the cosmetic related issues or suturing of mucosal flap, these are something which is, although its number reduced almost 60% from 10 to 4 or 10 to 6, but it is again faced by the third year. So when we calculated whether it is significant or not, then all the steps, second years having better result and lesser complication when we compare to the first year, even second years having, third year having lesser complication when compared with first second year, and third year and first year definitely have a greater p-values. So coming to the discussion, we find out that anatomical success rate in our study is much better in the third years who have performed at least 80 surgeries. Based on that, we concluded that if success rate is better when we give at least 15 surgeries each residency year, means after 45. So that is the method by we can quantify that at least a resident can get 15 surgeries in 1 year. Thank you very much. These are my references.
Very nice presentation and very good analysis. I have 2 points in one question.
Yes, ma'am.
So you have mentioned first, second, and the third year residents.
Yes.
Did you calculate or find out how many surgeries should be given to the first years, to the second years, and to the third years?
Yes, ma'am. I already mentioned 10,
you
15.
mentioned 15,
15 each in each group, 15 to 20, ma'am. We have given 15 to 20 cases for the first year.
No, to have a 100 100% success.
For
To be a
anatomical
successful
success,
surgeon.
45, 15 in first year, 15 in second year, and 15 in third year.
And secondly, in your study, there were 24 females and 11 males.
Sir,
Did you study that females' results were better
no,
than the
ma'am,
males?
it's not like that just because we have more resident. Even my first year resident, all 9 are females. I can't do so.
Okay. Thank you. Very nice.
Thank you, ma'am.
Thank you. I invite the next speaker on IMG Max, a comprehensive neuro-ophthalmology 3D touch interface application with augmented reality. Dr. Prasanna Venkatesh.
Yeah. Thank you for the opportunity, respected seniors on the dais. For the next few minutes, I'll be talking on the validation of one of its novel neuro-ophthalmological application that we have innovated called the IMG Max, which is one of its kind. So when we see a lot of theoretical framework happens in neuro-ophthalmology, when a structure is referred in a textbook, such as undissectable structures like a cavernous sinus, a circle of Willis, or even any brain structures for that matter, including the eyeball, there is no proper way or proper representation. There are many apps today on 2D or 3D animated one, but there is no app which has a real-time 3D interface or a pseudo 4D interface, which I'd like to call. And this we have incorporated along with subtractive learning. So you as a user can subtract the structures that you want to. You can see the button being clicked is the skin is removed. You can also choose the skull. Now the skull is removed. You can choose different frames of choice that you really want to examine. The meninges can be removed, the brainstem can be removed, and the brain. So you can just go ahead and use the buttons of your choice. You can have the frame of your choice, and you can go inside out with virtual dissection just at your fingertips with your smartphone. And you can see here, this is on the left hand side, the buttons can be subtracted or added. Depending on that, the structures can be made available. So we had to read the anatomy, and we had to make sure we did reconstruct all these structures from the anatomy from scratch. I had to refer a lot of books and had to recalculate it so that you'll have no blind spot in anatomy of the ophthalmology structures as well as neuro-ophthalmological structures, and gave it in subtractive learning and virtual dissection with augmented reality. So these are all the models that you can see that is readily available, and this is an offline app which has been innovated. And on the right hand side, you can see the novel feature here is this is augmented reality with the LiDAR scan technology that all the smartphones have today. With zero cost, augmented reality can be loaded, and the models can be available on the table. With the fingers, you can just rotate it, you can go through it, navigate it, and at any point you can see the structure. So this is the learning app that was actually innovated, right? In the next step, you can see that we also made some simulators with the app. This is me taking the phone towards the pupil and then coming back. So this 3D spatial orientation was another one that was added. So this itself can work as an offline simulator as well, as you can see on the left hand side. And on the right hand side of the video, you can see that there were many counseling tools that were made available as well, that you can see in this video. So the purpose, we did validate this app to see how the level of the classes were there. It was a cross-sectional study, comparative study on a Google platform, and predominantly we had neophyte users who were the downloads. So we approached them, and the components of the questionnaire were pertaining to knowledge, comprehension, and additive scientific 3D features that they felt were very important, and we did have some tutorials as well. And these were some of the highlight questions that we did ask them regarding the satisfaction of the curriculum, regarding the innovative methods that really helped them compared to the textbook teaching. Compared to this, we did have a satisfaction score, and through the mail, 217 invitations were sent, and we had 203 respondents, and the study period was had to 1 week. And the technical quality, the scientific satisfaction, and the financial aspect was also evaluated as to how they felt it comparable to with this application and without this application. And it was satisfied, neutral, and dissatisfied, where the responses arrived in a simple parity test, and it was significant. And I won't say it is that big a response, because 97.4% was happening with the app, and without the app also it's like 87% of the people were comfortable with reading. But this my dear friends, is one of its kind, where a three-dimensional orientation is needed, and it's order of the day in ophthalmology, where we have so many different three-dimensional structures. And when it comes to learning and pedagogy, because that is where it really starts. And this is not only applied in pedagogy, we can have the e-counseling stations, a simple procedure from AIOC PI, anti-VEGF injections, and retinal surgery counseling with the patient's own images. So we have used the patient's own fundus images, own angle images, own as much as neuro-ophthalmic images as possible to reconstruct this dimensional app. So according to our knowledge, there are no application till date which incorporates real-time, high-resolution, augmented reality images and photoreal visuals for interactive 3D learning. So this is the QR code. This is an offline app free of cost. You can scan this today and have this app in your smartphone today. It's offline. And neuro-ophthalmic concept learning along with ophthalmology is very immersive, and it also aids in patient counseling. And above all, we have also given a three-dimensional application model also for the same. If any user wants to download the app and as well as print their own models, such as the cavernous sinus or the circle of Willis that I'm having in my hand, they are also free forward to do it if they want to have it in a much digital way of expression. So this is the QR code, my dear friends, and immersive learning is the future. I think from neuro-ophthalmology is where we have to start with, so that the next set of batch is trained very well. Thank you for this opportunity.
Very nice presentation. You have mentioned that it is more of augmented reality. Is it augmented reality or it is more of auto segmentation? Because what I feel from the app, it is going more for auto segmentation, number one. And number two, if it is augmented reality, then can it be customized and use it intraoperatively? That is what we want, to be a very safe surgeon when we work in some very critical zones.
Yes, ma'am. This is actually augmented reality, ma'am. To an extent, I would say this is mixed reality or even extended reality. These three terminologies goes hand in hand. For want of time, I'm not able to do the demo, but in this, with the augmented reality, it can transcend to surgery as well. So, as you told about the intraoperative planning, for surgical transition, the smartphone alone may not be enough. That is where the HoloLens or the GeoLens, which is another part of my innovation, where I am working extensively on it also. With that, I think one or two people wearing the headsets, you can transcend into surgical innovations as well, where we have created the template. This template, we can superimpose a MRI or a CT picture of the patient, or even an MR angiogram or a CT angiogram can be superimposed. And then if you are dealing with a vascular tumor, or if you're dealing with a non-vascular tumor or whatever it is, I think you can go ahead and then plan the surgery with the headset, HoloLens headset. So that is also possible, and we have also done that also. So that is the next level is what I believe. Yeah.
Okay. Thank you.
Thank you, ma'am.
Thank you. Invite the next speaker, Dr. Seema Das, on time to diagnosis a newly diagnosed retinoblastoma, intermediate analysis form and in progress. Dr. Seema Das, please.
Thank you. Very good afternoon. Can I have my slides, please? So, INPOC RB 1901 is a prospective collaborative study on retinoblastoma in India. The study is conducted under the aegis of INPOC, which is basically the research wing of Indian Academy of Pediatrics, aimed at conducting collaborative research with the final aim of improving the outcome of childhood cancers in India. And on behalf of the study group, I'm going to present the interim data on time to diagnosis of this study. I don't have any financial interest or any disclosure. Retinoblastoma has the highest cure rate of all malignancies in the world. However, the reported outcomes from India are much inferior in terms of cure, ocular salvage, as well as vision preservation. And we all know that advanced presentation as diagnosis is associated with a suboptimal outcome, and delayed time to diagnosis is one of the major reasons for advanced presentation of the disease. Just to understand the concept of time to diagnosis, there is something known as parent lag time, which is basically the time when the symptom is first noted by the parents and the first consult is taken with the healthcare provider, versus the delay in the healthcare system, which is basically the first contact with the healthcare system and the delay for the diagnosis following the first contact. It is important to understand this concept to be able to address and optimize the delay, and this was the main aim of conducting this study. to see the epidemiological clinical features of retinoblastoma in India and to see the outcome following a standardized treatment strategy. One of the secondary objectives is to understand the reasons for delay in diagnosis, and I'll be presenting the interim analysis data on this point. All centers in India who are treating retinoblastoma were approached to join the study. A study outlines a standardized protocol and the treatment pathway was laid down. It was peer reviewed. Epidemiological, clinical, socio-economic treatment and the outcome data were collected, and all the centers got their ethics approval before and starting to enroll the patient. Till now, there are 20 collaborating centers who the study is still enrolling patients, and 1,000 patients has been enrolled till date. As far as the gender, age, and the laterality is concerned, this is at par is what is reported in the literature and in tally with what the global retinoblastoma study tells us. Leukocoria, as expected, was the most common presenting symptoms. If we look at the stage of the disease, stage 0 means the disease is confined to the eye and we are not able to say, we are able to save the eye. Anything beyond stage 0, stage 1 onwards is where the eye has to be sacrificed and needs enucleation. So this was at half of the patient in the study presented at stage 1 and beyond. And if we see the data of stage 3 and stage 4, which are basically extraocular and metastatic disease, 1/5 of the patient presented at extraocular or metastatic disease. Just to put it in a pictorial manner, it's a very crowded graph, but shows the distribution, geographic distribution of the patient across the country. But if you narrow it down, just to include the stage 3 and stage 4, which are the extraocular and metastatic disease, it seems to be concentrated mostly in the northern belt, northeastern, and some part of the central India. The distance the patient travels for treatment is an indicator of access to care, and about 1/3 of the patient in this study had to travel more than 500 kilometers to avail the treatment. Symptom to diagnosis in half of the patient, the parents seek the first consult within 1 month in just about half of the 50% of the cases almost. In other half, the consult was taken more than half, 1 month, and sometimes more than 9 months also. The first, as expected, the first healthcare provider to be visited was an ophthalmologist, but what was striking was even when the ophthalmologist was the first healthcare provider to be contacted, 38% of the cases the diagnosis was not made at the first consult, and on an average 3 consults were required before the diagnosis could be made. There was a significant correlation of increased time to diagnosis with when the strabismus was the presenting symptoms, when the distance from the treating center was more, low socioeconomic status of the patient, stage of the disease, and there was a negative correlation with improved parental education status. So to conclude, half of the patient in this study did seek the first consult within 1 month of onset of symptoms and were diagnosed within 1 month, but it also means 50% did not seek any consult within 1 month of symptom onset and were diagnosed later than a month or so. 1/5 of the patient were diagnosed at stage 3 and stage 4, where life salvage becomes very difficult. And there appears to be delayed recognition both by the family as well as a delayed diagnosis at the healthcare provider level, including the ophthalmologist. Prolonged time to diagnosis did correlate with the advanced stage at presentation. So what it means that if we have to make efforts to improve the outcome of retinoblastoma in India, it should be directed towards community awareness. Simultaneously, we need to have advocacy initiatives for routine screening during the contact with any healthcare providers, like the immunization, and the awareness and the training of the healthcare providers, including ophthalmologists, for better awareness and early diagnosis is an absolute must if we have to improve the outcome. We now have very good treatment modalities which is available, but unless and until we pick up the tumor at a stage where the disease is still inside the eye, having advanced treatment modalities is not going to make too much of a difference in the outcome in our setup. Also, half of the patient, even the diagnosis was, if it was established within 1 month, still half of them were stage 1 and beyond, meaning that in half of them, the eye could not be salvaged and it was an advanced intraocular disease. So whether there is a more aggressive tumor biology at our setup is something we need to understand and could pave the way for future research in this direction. So I acknowledge the contribution of all the participating centers, the co-PI and the study team, as well as CanKids, who has supported the funding for this study. Thank you for your attention.
Very nice presentation, Seema, and also the epidemiological study that you have conducted. My one question is, what are the barriers in the time to diagnosis, and what have you done to mitigate the barriers?
Yeah. So one of the reasons this study was conducted was not only to identify those barriers, but also to do some intervention to mitigate those. So what we found was distance was one of the reasons where, even if they were diagnosed, they were referred, they sometimes don't reach the treating center simply because they can't just travel. Financial reasons were there. So that's where the role of non-governmental organizations like CanKeys and other come into the picture, where they handle the patient right from the time of diagnosis to ensure that they reach the treatment center on time. And because these patients, we know that they need multiple rounds of travel for completion of the treatment. So that's one. Other treatment modalities like, even the imaging, something is, so expensive that many families cannot afford it. So the other advanced treatment modalities, if we have to save the eye, like ISC plaque is something which needs some sort of support. So these are all the barriers which seems to be also playing a factor in improving the outcome, because then those patient gets lost to follow-up. So all these were also addressed as part of the study.
Very nice. Congratulations. It's an eye-opener. Now you should work to mitigate the barriers and help that everyone gets this equal care all over India.
Absolutely.
Congratulations.
Thank you. Invite the next speaker on visual rehabilitation and quality of life with corneal contact lenses, corneal scleral contact lenses and irregular astigmatism. The author is Neetu Daniel.
So good afternoon, respected all the delegates present on and off the dais. Good afternoon to all. My topic for presentation is visual rehabilitation and quality of life with corneal scleral lens in patients with irregular astigmatism. So I have no financial disclosure. So the rehabilitation of patients with irregular corneas is very challenging, and it was previously done with lenses such as rigid gas permeable contact lens and later rose scale lenses. But however, corneas with very high keratometric values, these lenses are not very well tolerated. Hence, scleral and corneoscleral lenses are a better option. So as far as treatment option of irregular astigmatism is concerned, contact lens is a far superior solution, and more specifically, the scleral lenses. You can see in this picture, it's very much designed to vault over the irregular cornea, and it holds a liquid reservoir of non-preserved saline, and it lands on the sclera. And all the scleral lenses has an optic transition and a landing zone. So this is a video where you can see how the scleral lenses, they convert the irregular corneal surface to regular surface by maintaining a fluid reservoir over it, and provides a sharp vision by neutralizing the astigmatism and improving the visual acuity. I give the video credits to Silverline Laboratories. And the aim of my study is to assess the visual acuity achieved with corneoscleral contact lenses in patients with irregular astigmatism. And my primary objective is to assess the improvement in visual acuity and the number of visits taken to achieve the correct fit of these lenses. And my secondary objective is to assess the quality of life and patient satisfaction using a questionnaire and to record the complication. And the materials and methods, it was a prospective interventional study done in 32 eyes of 24 patients for a period of 1 year from July 2021 to 2022 in a tertiary eye care center. And my study population include those with corneal ectasias and post-LASIK ectasias and post-keratoplasty patients with irregular astigmatism. And the sample size calculator was 31 according to the following formula. And informed consent was taken from all patients, followed by a detailed ophthalmological evaluation, which included refraction, keratometry, and tomography, and followed by contact lens fitting. And the selection of for the contact lens fitting, we have to select the first trial lens, which is based on the cornea profile of the patient, followed by the fitting evaluation. After the lens is fitted, we check for the central fitting and the peripheral fitting. For the central fitting, we see for the tear reservoir. That is, as told earlier, there will be a non-preserved saline, which is mixed with sodium fluorescein. In other words, it's called the vault of the lens. So anywhere the central vault should be between 200 to 400. If it is less or high, we steepen or flatten the base curve accordingly. And for the peripheral fitting, we look at the lens landing. If there is excessive movement, we reduce the landing zone. If there is impingement, we increase the landing zone. Once both fittings are acceptable, we do an over the lens refraction and convert as per vertex conversion table. And any stain on the conjunctiva is not acceptable. And this is a video where you can see the central fitting of the lenses. We look for the reservoir, which is stained with fluorescein, and it should be anywhere between 200 to 400. This is showing an ideal central fit, and this is a third diagram is showing the different position, vault position of the lens. It should not be, there should not be too much of reservoir, not too less, causing the corneal touch. And this is an objective method to assess the central vault using AIOC2023. And for the peripheral fitting, we look at the blanching of the conjunctiva. This is a picture showing the correct lens insertion, and this is also an ideal lens landing, but this is an incorrect lens insertion which causes a conjunctival blanching. So this is a lens by the Silverline Laboratories we used in our study, which had a diameter of 14.5 mm. So a full day trial was done and multiple trials were done, and once a fit is confirmed, the lens is ordered. And we recorded the number of visits as well as we gave the click questionnaire to patient on day 1, 1 month and 6 months to be filled. And also we recorded the mean comfortable wear time. And these are my results. And it was almost 69% of the patients had keratoconus, and 75% of the patient nearly took 2 visits to achieve a correct fit. And when we look at the association between average central keratometry and the number of visits, we saw that patients with higher keratometric values, they needed more visits to achieve a correct fit. And when we see the best corrected visual acuity with corneal clear lens, it was 0.14 when compared to the mean baseline best corrected visual acuity or 0.5. And in 85% of patients, there was no complications. And when we see at the questionnaire, the contact lens impact and quality of life questionnaire, the row score and the person measure, it was statistically significant between day 1, 1 month and 6 months. And coming to the discussion, the corneal scleral lens seems to be an effective option, especially in corneal ectasias causing irregular astigmatism. And our study showed a statistically significant improvement in visual acuity, and also like the patient with an average central keratometry value of about 70 was able to tolerate this lens. So we can infer that it was a feasible option for even with higher keratometric values. And the mean comfortable wear time of the lens was around 7 to 12 hours, that is around 10.3. And the average total score obtained during the question using the question on day 1 and 6 months showed a positive correlation, which is statistically significant. And that indicated that the patient was satisfied using the lens at the end of 6 months. So to conclude, to the best of our knowledge, no previous studies have assessed the fitting, complication, and patient satisfaction with corneal scleral lens in a sample population in India. So we can, so it will be an effective option, providing a good visual acuity and an optimum visual quality in patients with irregular astigmatism. So the limitations are a smaller sample size and a short-term follow-up. These are my references. Thank you for your patient listening.
I have a question to you. Like you have mentioned in your topic as quality of life, you have not shown anything like functional disability and the functional benefit. So how did you assess the quality of life? Because the topic says it's both on visual rehabilitation.
So it was using a questionnaire, that is a contact lens impact and quality of life questionnaire, which is a 28 item, 28 questions were there, which was given on patient on day 1, then after 1 month and after 6 months. So in that questions, that's with the help of that questionnaire, we assess the quality of life.
Have you shown what is the functional disability and the functional benefit in those in the quality of life? Because that has not been shown in the results, and how will we know that the quality of life has improved?
Because the row score and the person measure is one that, ma'am.
Just one more question. Yeah. Did you compare with the Boston Prose lens, because that's the other corneal scleral lens that's
no, sir. We tried with corneal scleral lenses only. No comparison was not there. Because in corneas, with very high keratometric values, since CSL had a clear advantage. So, no, after fitting, no one was. Patient with C3R also had like we fitted this, yeah.
Thank you. Invite the next speaker on transconjunctival intralevator triamcinolone for upper lid retraction in thyroid eye disease, Dr. Shefali Chafar. This is in the category of orbit and oculoplasty.
A very good afternoon, everyone. It's an absolute privilege to be here presenting my paper titled Transconjunctival Intralevator Triamcinolone for Upper Lid Retraction in Thyroid Eye Disease. I have no financial interest. Thyroid eye disease, as we know, it is an enigma. The most common disease affecting the orbit. It is complex, yet it is poorly understood with an autoimmune pathology. So the thyroid stimulating antibodies act on the orbital fibroblasts and can cause a lid retraction, myopathy, proptosis, optic nerve dysfunction. Also, it is an enigmatic disease which undergoes a dynamic phase which is active and a static phase which is inactive, popularly called as the Rundle's curve. The most common eyelid symptoms that we come across is eyelid retraction, which is seen in actually 90% of the cases. And the mechanisms that have been proposed for the retraction is overaction of the levator and the Muller's muscle because of the increased sympathetic tone, levator hypertrophy, levator muscle contracture or fibrosis, abnormal additions between levator and surrounding structures, scarring or inflammation of the septum and the anterior lamella. So what are the challenges that we face here? They can be functional, causing lag of thalamus or exposure keratopathy, or cosmetic, which can be a very big psychosocial impact on the patient. And the management options that we have on our hands are surgical or non-surgical. Surgical options, as we know, can be done only in the inactive stage of the disease when the fibrosis has set in. So when we see the surgical option and the papers that we see on levator recession, the mere number of papers that have been published can actually prove that there is no standardized treatment that still exists for the surgical option of lid retraction in thyroid. Also, as a clinical experience, we know that the patients are not very happy with the flattened lid contour that we get post-surgery or with the higher lid crease that we can get. So it is not very predictable. The non-surgical options also have been studied in the terms of hyaluronic acid injections, which are temporary and unpredictable, and also botulinum toxin injection, again temporary and unpredictable. So we had few pertinent questions in our mind, and with these questions in our mind, we set out to evaluate the role of transconjunctival intralevator injection, which was given to 22 patients in 37 eyes. It was a retrospective interventional case series done between January 2019 and August 2022. And all the patients underwent triamcinolone injection in an OPD setting with a 26 gauge needle subconjunctivally with the needle directed towards the levator muscle. Coming to my analysis, the mean age was 46.2 years. Females were 13, more than males, and bilateral disease was seen in 13 of the cases. Interestingly, in our study, inactive thyroid eye disease cases were more. There were 16 and active was 6. And they were a mixed group of hyperthyroid, hypothyroid, and euthyroid on systemic treatment and stable disease. So this is just a representative case of an active thyroid eye disease. All the patients underwent a detailed ocular examination and photographic documentation. Clinical activity score was calculated. Superior scleral show, palpebral fissure height, and the lag of thalamus was measured. And after the injection in the active group, we gave the injections after 3 cycles of intravenous methylprednisolone. And the results were satisfactory. And again, we measured the superior scleral show, PFH, and lag of thalamus, and subjected it to analysis. This is another case which is from the inactive group. Again, the patients underwent all the measurements. The observation in our study was the inactive group had to undergo more number of injections as compared to the active thyroid disease group, and the results were very satisfactory even in this age, even in this group of patients. So the mean number of injections that we had to use was 1.7. It ranged from 1 to 4 with an average of 2. Mean average dose was 23.7 milligrams, and time to maximal response was a mean of 37.6 weeks. And all the measurements that we did, MRD1, PFH, superior scleral show, and lag of thalamus, all of them had a statistically significant difference pre and post treatment. The mean follow-up was 16.3 months. The MRD1 was 4.5 millimeters, which showed an improvement in all our cases. Mean reduction in MRD1 was 1.5 millimeters. There was no significant regression from the maximal response, and only one patient showed a transient increase in the intraocular pressure, which settled down by the next follow-up visit. So these are just some of the results from our case series, which showed excellent and gratifying results. So the questions that we set out with could be answered with our case series, that it can be effectively used in active and inactive thyroid eye disease. 1 to 4 injections were utilized. It has a long-term effect. The cases were stable for more than 6 months of follow-up. There was no local or ocular side effects that we could find, and it could be very effectively used even as a functional benefit or for a cosmetic benefit. Handful of studies exist in literature, none from our country. So this is the first study which proves that it can be used. Interestingly, in our case series, inactive thyroid disease patients were more. Also, we did not have any ocular or local side effects. So the mechanisms that have been proposed for the functioning of this injection are anti-inflammatory effect, aponeurotic detachment or the myopathy causing ptosis, or the thinning of the muscles, that is LPS-SR complex, which can happen because of the steroid injection. So in conclusion, I would say that it is effective and long-lasting modality to treat upper lid retraction is lacking. It is a very challenging situation. Non-surgical treatment options like triamcinolone injection, they have an ease of administration. It is a short downtime. It also can be effectively used during active phase where none of the other things work. It helps improve the quality of life of the patient, and definitely it broadens our therapeutic arsenal to help these patients. Thank you so much. These are my references for your patient.
Very nice, Shefali.
Thank you, ma'am.
Did you get any recurrence in any of these patients?
No, ma'am, none in our series of 22
So
patients.
maximum 4 injections.
Yes, maximum. The inactive disease, 4 patients were there in our series who had to undergo 4 injections, ma'am. Active disease patients, 1 to 2 injections work very well.
The IV methylprednisolone was given every time?
No, sir, only in the active disease patients, sir. If the disease was active, we started off the IV MB pulses, and after 3 pulses, we, if it was required, then we went ahead with these injections.
Thank you.
Thank you, sir.
Invite the next speaker who will tell us about posterior phakic intraocular lenses for the treatment of refractive amblyopia in children and adolescents. Dr. Arvind Moria.
Good afternoon, respected judges and my dear friends. So my talk is on posterior phakic intraocular lens for treatment of refractive amblyopia in children and adolescents. So amblyopia is a neurodevelopmental ocular disease manifested as monoocular and binocular impairments, including vision reduction, contrast sensitivity, and loss of stereoscopic vision. And commonness of amblyopia is classified as refractive, anisometropic, and isometropic. Occlusion therapy has its own problem with recurrence of 25 to 50%, and contact lenses too has a problem of poor compliance and intolerance. So this was the first clinical trial registered with NIMS ICMR. So we used the phakic IOLs in children and adolescents of 10 to 19 years. As per literature, this is the first world such study with the this much of sample size and in this age group. So our purpose was to analyze the demographics and clinical outcomes of posterior chamber phakic IOL for refractive amblyopia in children and adolescents. This was our methodology: prospective international study on children and adolescents with amblyopia at a tertiary eye care center from January 21 to January 23. 23 eyes of 21 anisomyopic and isomyopic amblyopia patients operated for phakic IOL as a treatment for amblyopia were included in this study. Patient demographics: pre and post-operative visual acuity, cycloplegic refraction, anterior and posterior segment examination, IOP, pachymetry, contrast sensitivity, endothelial count, stereoscopy, and patient satisfaction scores were evaluated. And inclusion criteria: stable refraction, and the patient who were not improving with the occlusion therapy, and contact lenses, ECD of more than 2500 and ACD of more than 2.8 millimeter. Patients were followed up day 1, 6 weeks, 3 months, and 18 months after surgery, and all the records were documented. Exclusion criteria were patients with hypermetropic amblyopia, strabismic amblyopia, or with any history of glaucoma, active inflammation, cataract, previous intraocular surgery. These were our results. Demography: the mean age was 14.16 plus minus 3.49 years, and 52% were male and 47.83 were female. And this table depicts the mean and standard deviation of preoperative vision uncorrected to last visit. So preoperative uncorrected distant visual acuity improved from 1.39 to 0.17 with a significant p-value, and the preoperative best corrected distant visual acuity also improved from 0.40 to 0.11 log mar. And this table depicts the uncorrected visual changes from preoperative to third visit after operation. So this is the mean difference. So preoperative vision 1.11, so it improved to 0.05 with a significant p-value of 0.003. And in terms of gain in visual acuity lines, the uncorrected visual acuity and the best corrected visual acuity during the post-op visits. So from day 1, uncorrected visual acuity, the gain was 11.3 and it improved to 12.1 at the last follow-up. And the best corrected visual acuity also improved 1.3 line to 2.6 logmar lines. This table depicts the comparison of contrast sensitivity that also improved from 1.07 to 1.66 with a significant p-value. As we compared the IOP, there was no significant p-value difference. It remains the same from 15.25 to 15.29 at the last visit. And this table represents the preoperative and the postoperative endothelial cell count. So there was a loss of 5.78%. And on the Likert scale, this was the patient satisfaction rate. 74% were extremely satisfied and 24% were very satisfied. As we compared the stereo acuity, so this was most plastic and rigid to improve. So from more than 800 arc second of mean, it improved to 150 at the last visit, and only at the last visit there was a significant p-value difference. So in the discussion part, so AIOCG, they have done the same thing for the treatment of anisometropic and amblyopia in children. They have a longer follow-up, but it was a retrospective study and they included lower age group with a sample size of 11. As compared to the SLKK study, they use the varus eye ACIOL, so it has own complications. Jang et al, they also use this technique, but the sample size was 11. So in conclusion, phakic IOLs can be a preferred choice for management of amblyopia in children with no incidence of corneal haze and ectasia, good refractive results with stability and good quality of vision, faster visual recovery with flat learning curve, no PI is needed in newer design phakic IOL, more multicentric clinical trials with long-term follow-up are needed for results to be more conclusive, and stereopsis takes longer time to improve. So sometimes opting for the simplest of the surgical procedures, we are able to treat the most complicated of the problems. Thank you. Thank you so very much.
2, 3 just comments. You have included the patient till January 23.
Sorry?
January 23. You have in your inclusion criteria, all the study material in the patient recruited.
No, the follow-up.
But follow-up till January 23.
Yeah.
But you have submitted your paper probably in August, September.
So we have included the changes which has happened.
Anyway, and the second one is you have not mentioned how many patients actually completed the third follow-up visit, how many patients has, then the statistical points actually mean something. Otherwise, there is nothing written there, how many patients completed first follow-up, because this is a problem in India, how many patients completed the fourth visit. And again, another point is you have not grouped all the patients because you have a different age group. It is better to understand because these are amblyopic aged patients, so we know that the earlier we intervene, the better the result. So you have a large. So my suggestion will be that you should group this so that you can understand better which group are actually improving so much, which group. You have generalized everything.
We have included only the isomyopic and the anisomyopic type of patients.
Age group of the patient I am talking.
It was mean age of 14.1.
No, I'm not talking about mean. If you take from 6 to 14, then you should have 2-3 groups because they are growing age. So there might be some different in understanding how some people are, some child are actually improving, some of it. When you group together, then average figure doesn't mean anything actually.
10 to 19 years.
10 to 19 years. Okay. Yeah. Any question? Okay, thank you.
Thank you, sir.
Thank you. Invite the next speaker. We'll talk on applying collagen understanding to refractive assessment, treatment, and evaluating outcomes. Dr. Pooja Kamar.
Thank you, sir. At the outset, none of the authors have any financial disclosures to make. So, it's not moving. So why as refractive or corneal surgeons, we need to understand or study the collagen? We already have multiple topography, biomechanics, and OCT-based indices, which helps us to differentiate normal from suspect corneas. However, we do come across cases where topographies and biomechanics are normal, but sometimes topography and biomechanics don't match at all. And there are times when a patient with normal topography and biomechanics land up developing ectasia and vice versa. So what is happening here? What are we missing here? Our group has published in the past that patients with normal topography and biomechanics who landed up developing ectasia had pre-existing lower levels of collagen in eyes developing ectasia. So collagen fibrils are nothing but they provide the biomechanical prerequisite which is necessary to sustain the shape and provide strength to the cornea. So answer was collagen. But at this point of time, the only way we can measure or know the collagen level is to excise the corneal tissue, but it is not a practical option. It is challenging, and of course, it is invasive for normal patients. So our research question was, is there a non-invasive way to study the collagen fibril orientation and distribution, and can we translate this knowledge into clinics for screening of refractive surgery patients and choosing the right procedure? Polarization sensitive light has been there in ophthalmic practice for more than 10 years now. So we use the same polarized sensitive light and developed an OCT where the polarized light is projected on the cornea. All the layers of the cornea will take up this light, but the stroma will show the bifringence property and refract the light. So we took advantage of this property and developed our custom built polarization sensitive OCT, which had an added advantage compared to the commercialized OCTs. They had a maximum detector bandwidth which was higher than others. The full depth in pixels and the pixel resolution was also much higher compared to the other OCTs which are already in practice. So what information it gives us? It gives us epithelial maps which are of 11 millimeter zone, which are not extrapolated like the existing OCTs. It gives us the Bowman's thickness, whether it's normal or whether it's thin, because a thin Bowman's membrane can, if you do a surgery on these patients, they are unable to maintain the integrity of the corneal structure post-surgery or because of any trauma. So this is the first ever tool to quantify the Bowman's layer thickness. This is how the collagen distribution looks like theoretically, and the colored maps, what you are seeing here, comes from the polarization sensitive OCT. To simplify, the denser the blue or violet the color, that means the denser the quantity of the collagen is and the orientation of the collagen is in that area. The lighter the blue, that means weaker the collagen is in that area. So this is how a normal looks like. And in a formfrust keratoconus and in a keratoconic eye, you'll see partial loss of orientation and arrangement of collagen. And here you'll see a complete loss of orientation and arrangement of collagen in these eyes. We also have developed in this machine that where you can also see the orientation. Ideally, it's perpendicular to each other, but whenever there is a suspicious topography of early formfrust keratoconus or a keratoconus case, the perpendicular alignment of this collagen fibers start getting distorted and which can be studied. So in addition to density, you can also study the alignment of the collagen fibers. Now, how does PSOCT helps us in identifying the suspicious cases? We have designed the study with 535 normal patients, 349 suspicious cornea patients, and 337 clinical keratoconus patients. They underwent detailed clinical evaluation, corneal topography, biomechanics, epithelial mapping, and in vivo collagen distribution imaging using custom-built PSOCT. So these are two case examples. Case 1 has a suspicious looking topography and suspicious indices. Case 2 is a normal topography with normal indices. However, after refractive surgery, the first patient is still doing well, whereas the second patient, where everything was normal, has developed ectasia. Fortunately, we had done a polarization sensitive OCT when we developed this machine for this patient, and on retrospective analysis, we found that the first patient had a healthy Bowman's membrane and a healthy looking collagen and distribution. However, the second patient had a thin Bowman's membrane and a complete loss of orientation and arrangement of collagen, which could have probably led to ectasia in this patient. So looking at this, we developed a nomogram where we divided these patients into 4 groups. The first group had normal density of collagen and distribution with a thick Bowman's membrane. The second group had normal collagen distribution but a thin Bowman's membrane. The third group of patient had abnormal collagen distribution but a thick Bowman's membrane. And the fourth group of patient had weak collagen distribution and a thin Bowman's membrane. Based on this, the first group of patients received refractive surgery based on surgeon's preference. The second group of patients, for low dioptric correction, they received a SMILE extra or a PRK surgery, and the patients with high refractive error received a phakic IOL. Similarly, for group 3, the lower dioptric patients received PRK extra procedure, and the higher dioptric correction patients received phakic IOL, and the fourth group also received phakic IOL. We also studied how the post-refractive surgery patients behave, and we found that there was nil to minimal change in collagen distribution patients post-PRK surgery, followed by SMILE and LASIK. So this is the first polarization sensitive OCT in the world which is used in clinics to study the orientation and arrangement of the collagen fibers. It helps us to differentiate healthy from suspicious corneas, and because suspicious corneas do reveal a unique distribution of collagen indicating early changes before their topographic manifestations have started. So it can be included in our refractive surgery screening in future as we go on. So we have now developed indices. We have got the regulatory approval through which we can commercialize this PSOCT in practice. We are also using it for retinal imaging, glaucoma imaging in our practice, and we are incorporating the confocal microscopy imaging in the same tool. Thank you.
Very nice, Pooja. But I saw that you have compared this with biomechanics also. So did you find a correlation between the collagen arrangement and biomechanics? Did it correlate? So if you find a red flag on biomechanics, will you get a different arrangement on collagen?
Yes, sir. So what we have found that the more than CBI and TBI, SPA1, which is the stiffness parameters, has a better correlation with this collagen fiber, because that's the true stiffness parameter where it negates the scleral biomechanics and only gives us the true corneal biomechanics. So we do have found a correlation with it, with which we have developed another nomogram, but that needs validation. So maybe for
now this machine nobody in the world has.
So
this is your original work, right?
So this is an original work, and before we presented, so when I submitted this abstract, it was not, it was approved by regulatory body, but not for commercialization. But recently, a company has taken it over, and they are going to commercialize it once they have approvals from their end. So it's going to be commercialized soon, and it's going to be one of the companies which is dealing with topographers and biomechanics.
Very nice.
So they have already taken it up.
Just one question in terms of how did you validate the thickness of Bowman's layer? What your machine measured and what is the actual measurement?
Sir, so when this machine gives us a high definition OCT, so where you can actually indent the Bowman's membrane and you can quantify it manually, and it also you can correlate it with the software. And what is the normal thickness, what is the thin Bowman's membrane thickness is based on the literature. So if it's less than 15, the average is 14 to 18. If it's less within that range, it's normal, but below 14, it's thin Bowman's membrane, which is based on the literature thickness.
No, what I meant was what your machine has given a measurement, and if you take the cornea and do a histopathology and actual do a measurement, did you have correlation between the two?
So that is yet to be found, but the correlation of the actual Bowman's thickness comes from the literature, where they have done the histopathological evaluation of the Bowman's thickness.
Yeah, because this is the only device you have. There is nothing else that we can use to compare. So I think that also validation is important because you are basing a lot of your suggestion based on thin or thick Bowman's layer.
Yes, sir. Thank you.
Very good.
Thank you, sir.
Invite the next speaker on surgical outcomes of full tendon modified Nishida procedure in varied large angle complex strabismus in the category of squint.
Good afternoon, everyone.
Dr. Shweta.
I don't have any financial disclosures. Transposition procedures are often the procedures of choice for large angle concomitant squint for correcting large angle primary position deviation as well as improving ductions past midline. But recessing tight antagonist with full tendon transposition can bear the risk of anterior segment ischemia if done in the same sitting, and even if spaced in time, the procedure doesn't become safe. So the partial tendon transposition and modified Nishida are safer alternatives, but the efficacy remains low as the vector used in these procedures consist of 1/3 of the muscle width with mean correction up to 30 prism diopters only. We have published a paper with no split, no tenotomy, full tendon modified Nishida procedure in a rare case of bilateral medial rectus aplasia with large exotropia and adduction deficit with good surgical outcome. So the aim of our study was to evaluate the safety and efficacy of our previously described no split, no tenotomy, full tendon modified Nishida in correcting large angle deviation in various complex strabismus. Medical records of patients were retrospectively reviewed, and patients who underwent this procedure with a follow-up of 6 months were included. Informed consent was taken. Records of complete orthoptic workup, including deviation and surgical details, were noted. Ductions were measured on a scale of 0 to -4. Pre-op deviation and post-op deviation were compared using Wilcoxon sign rank test. Median correction achieved by this procedure alone was calculated for every patient and for all types of incomitant squint. Median vertical and horizontal correction and median correction for all type of incomitant squints were compared using Kruskal Valley with Bonferin correction. This is the short video of our procedure. Traction sutures were given and limbal incision were made temporally. Then the muscle which has to be transposed, that is superior rectus, was isolated and 8 mm mark was made. The muscle was secured full thickness with the help of non-absorbable suture. Then the paralyzed lateral rectus muscle was hooked and 14 mm was marked from the limbus close to the superior border of the lateral rectus, and sutures were passed through the marked site. Now the same sutures were passed through the superior rectus and the muscle for the mobilization of the muscle. Now similar procedure was done on the inferior rectus. 8 mm was marked and again 14 mm was marked from the inferior from the limbus along the inferior border of the lateral rectus, and the similar procedure was performed there. The key points in our technique was that whole width of the muscle was secured by passing non-observable sutures, and sutures were passed close to the border of the paralyzed muscle, and the whole muscle was mobilized and transposed, unlike in modified Nishida in which 1/3 of the muscle was used and the sutures were taken midway between the horizontal and the vertical muscles. So coming to the results, there were 22 patients who underwent this procedure. Mean follow-up was 2.7. Among them, 6 patients were pediatric. Mean age was 24 years. Among them, 10 were congenital. There was no sign of anterior segment ischemia in any of the patients. We had 7 MED patients. All had severe ptosis with poor LPS and poor Bell's. All 7 patients underwent this procedure, and 6 patients additionally underwent IR recession. Mean pre-op hypotropia improved from 65 to 18 prism diopter at 6 weeks and 4 prism diopter at 4.29. Mean pre-op supraduction improved from -4.29 to -1.36, which was statistically significant. Mean correction achieved by this procedure alone in 7 patients was 52. Bell's improved post-operatively, following which ptosis surgery was done in all patients. These are the photographs of other patients showing correction of hypotropia in the primary position. And this is the 9-gaze photograph showing improvement in supraduction without compromise of the horizontal movements. Then we had 8 patients of 6 nerve palsy. All patients underwent this procedure along with MR recession. Mean pre-op esotropia improved from 65 to 10 prism diopter at 6 weeks and 2.25 at 6 months. Mean pre-op abduction improved from -4.29 to -1.36. Mean correction achieved on this on the temporal size was 41.75 prism diopters. These are the photograph of other patients showing improvement in abduction. Then there were 3 patients of lost muscle. Mean pre-op exotropia improved from 71 to 21, which was statistically significant. Mean pre-op and pre-op adduction deficit improved from -4.6 to -2.7, and mean correction achieved on the medial side was 51.67 prism diopters. Then there were 2 patients of esotropic DRS. Mean abduction improved from -4 to -1, and correction achieved by this procedure on temporal side was 30 and 25. Then there were 2 exotropic DRS patients. Mean abduction, both of them underwent LR periosteal fixation and full tendon modified Nishida on the lateral side. Abduction improved from -5 to -2, and the correction achieved was 25 and 30 base out prism diopters. So the overall correction achieved by this procedure alone was 44. Vertical correction gave around 53 and horizontal correction gave around 40 prism diopters. The correction achieved by the ESO-DRS and EXO-DRS were lower. Overall p-value for this procedure among all types of incomitant squints was statistically significant, but applying Bonferroni correction for multiple comparisons, the adjusted p-value for every group comparison was not statistically significant. So the strength of the study was the novelty of the procedure, the benefits of full tendon transposition without splitting and tenotomy, without compromise, without any sign of anterior segment ischemia, and with a follow-up of 2 years. Limitation of study was the small sample size was restrictive squints. So full tendon transposition myopexy is a safe and alternative procedure in correction of large angle strabismus and improving ductions when done with or without ipsilateral antagonist recession. Thank you.
A nice presentation. What are the vertical complex strabismus you have taken?
Only MED.
Okay. And how much was the maximum collapse of the angle in those cases?
maximum collapse was the first patient which I showed. It was 90 prism diopter because this patient came to me after IR resection.
Okay.
So I had like 45 degrees, that means 90 prism diopters, and this gave as good as 90 prism diopter. Some of them gave less, and so our average was around 55.
Okay, so maximum 55% collapse
This
you
is the
got.
median value, but
Okay.
maximum I got 90 prism diopter with this procedure alone.
This modified Nishita. Very good.
Thank you. Invite the next speaker who will tell us about documentation of trauma with a smartphone kit, Dr. Prithvi.
Good afternoon, everybody. So I'll be talking about documentation of trauma with Smart Scope Kit. So we have already seen how Smart Scope Kit is used in patient screening for the outreach programs. Here we will see that how the eye represent 0.27% of the whole surface body area, but still it's the third most organ to be affected, and it becomes a very major cause of visual morbidity, and the higher incidence is higher in the developing countries. And global annual incidence by WHO has given 55 million trauma cases and 16 million going blind. So it becomes very essential that we take a good medical history and a thorough ocular examination to conduct the management of these ocular trauma. And while the doctor is actually managing this, he forgets to do one major thing, that is documentation. So documentation becomes very important for a plan of treatment. If we want to counsel the patient for the prognosis, whether it's good or bad, and it becomes very essential for teaching as well, and most importantly medical legal cases where this takes into consideration. And we know that paper medical records, handwritten, is very difficult, is disorganized, illegible, and EMR takes time. It takes time to document, and also the next person who sees is not able to comprehend how it is, what is written properly. And there are articles that documentation also should always be supported by photo documentation. But as you can see, most of the ophthalmologists in their clinics do not do a photo documentation because they don't have the actual equipments for that, because it's expensive, accessibility is less, the availability of these instruments are not possible every time in every place. It is very bulky, cannot transfer the instruments. Portability becomes an issue, especially in ICU patients, and also these are not very handy. So to reduce all these things, all these problems, we've introduced the Smart Scope Kit, as we already seen. So over here we use the eye handbook, a free application to check the vision testing. And then we have the other few instruments like a pinhole and occluder to get the visual acuity as soon as possible. These are all the systemic investigations that we have for the trauma cases to be checked. And the major problems are in the anterior segment area where we cannot document, and these are the instruments which we use over here. So iVerter and the universal speculum helps us to take the foreign bodies. And anterior segment with intraocular lens, ASPE, is used for taking images of the anterior segment at the corneal level, the sclera, the iris, lens. And we have a range of 15 to 25 diopter lenses where you can increase the magnification by using 25 diopter lenses. And if you need a higher field, we use 15 diopter IOL lenses. And as you can see, these are all the images that we have taken: a metal foreign body, fat prolapse, lens subluxation, iris prolapse, hypopyon, hyphema, corneal tear, rosette cataract, iridodialysis, traumatic cataracts, keratoplasty dislocation. So all these are we have been able to take without a slit lamp, and this can be done by anybody. And over here you can see how an 8 diopter IOL has been used to take this image of the angle recession. Just to mention about the IOL scope, because it's there in the Smart Scope Kit. Over here we actually use four 30 diopter lenses together, and we have been able to develop one IOL which is one of 150 diopter also. Not that it's very important in the trauma. Then we have the Scooby-Doo. Over here we have the lens along with the blue filter which has been attached, and this can be used in a lot of cases such as this one, where you can see the Seidels positive test. So this is actually not taken with the slit lamp. It's purely taken from the smartphone with the cobalt blue filter attached to the flashlight. And then we have the posterior segment raster pressure red cam, which we can use the any kind of a waste hand sanitizer bottle. And by attaching a 20D lens, you can actually take all the posterior segment images. And this is very easy to actually assemble and take images of. And with this, we were able to take images of choroidal rupture, traumatic macula hole, metal foreign bodies, scleral foreign bodies, especially RedCam, which is very handy and we can be used anywhere. So as a result, we had more of cornea and retina cases. And I would like to tell that this is a work of 5 years that we have been able to do and bring it onto one particular kit. And this kit is very effective for documentation of trauma related findings, and especially where people are not able to take images of these. It helps in counseling trauma patients about the prognosis, and can also help in medical legal cases when we have a photo documentation in hand. It becomes very easy for us to prove our point. And this kit has actually, as I said, it's a work of 4 years, which we have been able to cut down each and every part of the slit lamp, and made it such a small, easy to do it yourself instruments, which can be done by anybody in their clinics. They can make it and they can use it for the benefit of the doctors and the patients in a very efficient way. Thank you.
From our side is only except 4 or 5 clips. Both the papers, number 2 and your paper are same, except the few pictures, that Siddle test, and 1 or 2 such. So this is wrong thing actually. So you could combine together, adding those 3 slides more in one presentation, because we are seeing the whole thing, doubling the whole thing. Yeah, I'm sorry to say that, but I do not know comments from other judges. Kumar?
I would like to say that there are two different aspect and application of the same instrument. The instrument was same, and we have used it for 2 different aspects. One is for patient screening, and the other one is for the doctors to help them document. So actually, it's 2 different studies, but with the same instrument. That I would agree, and I actually wanted to show how it can be done by a doctor, very simple, very easily. So this might look very simple, but it has taken 4 years, and it has made it simple because we want people to actually replicate it and use it in their practice for patient counseling also and for the doctor also. So this were 2 different studies that we did, but with the same instrument. I agree with that, but it is for the benefit
Dr.
of
Prithvi,
both.
I just wanted to congratulate you on it's a very nice paper. But the thing is, you're talking about, it has been around for 4 or 5 years. Has it been commercialized? But are people really using
Actually,
it?
we have used it. We have validated each one of these instruments
not you. I'm talking about, has it been commercialized so that people who don't have access to portable equipment have started using this?
I have not commercialized it yet, but there are a lot of people who I know who are using these instruments right now, and they're doing it in all these periphery centers also. And but I've not commercialized it. I don't know if there are other people who have commercialized it, but I try to keep it more simpler and so that everybody can replicate it. That's the main point.
Thank you.
So we call upon the next paper, the homemade do-it-yourself aqueous sampling device for anterior chamber tapping endophthalmitis. Dr. Sangeet Mittal.
Good afternoon, everyone. So I'll be discussing about the homemade aqueous sampling device. So endophthalmitis could be post-operative, post-traumatic, endogenous, or secondary to keratitis. And rapid diagnosis and appropriate treatment is required to save the eye from irreversible blindness. Accurate, appropriate, and adequate sampling is the key to this precise microbiological diagnosis. So specimen we can obtain is either the vitreous taps, the biopsy, or the vitrectomy fluid, which are more sensitive, but they have to be performed in the operation theater by a retina specialist. And considerable time is lost before initiating the treatment, leading to further growth of organisms inside the eye and cause worsening of the condition. So aqueous tap can be easily done by a comprehensive ophthalmologist and can be done before referring the patient to a retina specialist and get a precise and accurate microbiological report. So the purpose of the study was to compare an aqueous tap performed by this novel aqueous sampling device with the conventional sampling method using a 26 gauge needle mounted on a tuberculin syringe, and to compare the sensitivity results of this aqueous sampling device with a vitreous biopsy. The design was a randomized controlled clinical trial. So this is how we routinely do a conventional method. You use a tuberculin syringe and you use a 26 gauge needle. But the problem is that you have to control it because your both hands are just holding the syringe. The control is very difficult, and you have an assistant is usually required to hold the globe if you are doing it in the topical anesthesia. So a cut 2cc syringe is then attached to a rubber suction bulb, and a 26 gauge needle is mounted on the syringe. And you see a small hole in this bulb acts as a safety valve, and vacuum is created by pressing the bulb after covering the hole. And you can see that the fluid can be aspirated when pressure over the bulb is lifted. So seeing this live on a patient, this 26 gauge needle is inserted into the anterior chamber after creating vacuum. The pressure is released slowly as aqueous fluid collects in the syringe. Needle is then withdrawn and fluid is sent for microbiology. So we divided 40 clinically diagnosed cases of endophthalmitis equally in two groups. Group A was the conventional technique, the 20 cases with aqueous tap using a 26 gauge needle mounted on a tuberculin syringe, and Group B was the 20 cases with aqueous tap using this novel device. All samples were collected by ophthalmologists in operation theatre under peribulbar anesthesia. Aqueous tap was followed by vitreous biopsy and injection of intravitreal vancomycin and ceftazidime. After collection, samples were sent to the laboratory for immediate inoculation and gram stain. So positive result meant the organism detected on either the gram stain or the culture, and the results also compared with the vitreous biopsy to rule out any false positives. The results, the two groups were equally divided into the cause of the endophthalmitis, the postoperative, the post-traumatic, or the endogenous. And the aqueous samples sent by the group 1, that is the conventional technique, 9 were returned by the lab as a quantity not sufficient, whereas 5 by the novel device group were returned by the lab as the quantity not sufficient. The samples were processed 11 in the group A and 15 in the group B, and positive result was obtained in 27% cases of the group A and 60% in group B. So there was the vitreous biopsy was sent in all those cases, and the positive result was seen in 15, that is 75% in group A and 70% in group B. So comparing the two groups, the aqueous sampling device was found to be more accurate, that is 87%, as compared to the conventional sampling device. The sensitivity was as high as 81.8%, as compared to conventional sampling, which was 42.9%. The specificity, because there were no false positives, was 100% in both the groups. The advantages of this device is that adequate sample can be obtained, no need of an assistant. Sample can be obtained by a comprehensive ophthalmologist. Sample can be taken without delay at the primary center. Positivity is comparable to the vitreous biopsy and can be prepared immediately. This device can be prepared in the operation theatre, or it can be pre-prepared and sterilized for later use. The limitations of the study include a very small sample size, and it was not truly a blind or a double-blind study. To conclude, though vitreous is the best source for obtaining a specimen for culture or smear examination, the aqueous sampling device is easy to use, and an aqueous sample is obtained before giving an intravitreal antibiotic by a primary ophthalmologist. It gives adequate positive results, thus avoiding delay in treatment and worsening of disease. Thank you.
How do you control the amount of the fluid which you take?
So there is a small hole in the dropper. And by just putting a finger on that hole, you can control the flow of the fluid into the syringe.
I think you can also push back some fluid in case you are losing the antechamber depth. I think that is also a possibility. I think with this.
Thank you.
Thank you.
Invite the last speaker. A novel genotype, phenotype, correlation and exploring potential for gene therapy in Stargardt's disease.
So good afternoon everyone. So as we all know, Stargardt's is the most common inherited juvenile macular degeneration, and ABCA4 gene mutation being the commonest in 85% of Stargardt's. The ABCA4 gene is located in chromosome 1. Basically, it codes for a transport membrane protein on the membrane, which involved in all trans retinaldehyde removal for rhodopsin synthesis. So, whenever there is a mutation in ABCA4, there will be inefficient degradation, thereby excessive accumulation, apoptosis, and disease manifestation. Our purpose was to report novel phenotypic patterns, genotypes, and possible gene therapy prospects in Indian patients. It was an observational study with clearance from Institutional Ethical Board. This was the roadmap for our study to identify families with Stargardt disease, identify and isolate the mutation, studying these mutations in cell lines, and how to repair this mutation, and to study the effect of repair. Our study cohort had 39 families, 50 affected, 94 unaffected. For genetic testing, we used whole exome sequencing to identify and isolate the mutation. All patients underwent comprehensive evaluation and imaging. Electrophysiological tests were carried out with strict adherence to ICF protocol wherever it was required. So our cohort had 29 males and 21 females, age range between 9 to 64 years, and history of consanguinity was present in 28 families, that's approximately 73%. A spectrum of fundus abnormalities were observed. This was 28-year-old male with a typical Stargardt's with flex and atrophic macula, had homozygous mutation ABCA4. This was one more 30-year-old female with better vision, but there were no flex, just a ring of hyperautofluorescence. And there's one more 46-year-old patient with extensive degenerative changes with outer retinal cavitation and choroidal changes. All of them had a same mutation, but these kind of changes were never reported. So this was one more interesting family where the proband was 14-year-old female, mother was asymptomatic, the daughter had atrophic foveal changes, and she had compound heterozygous mutation in ABCA4. That means mutation at two different locations as opposed to homozygous mutation. But mother was homozygous for one of these mutation, but she was asymptomatic. When you did the autofluorescence, there were changes in the peripheral region. A ring of hyperautofluorescence was seen. Maybe this is a very mild mutation which is causing mild disease in the mother. The combination of mutation is causing severe disease in daughter. This is typical example for a same family, same disease, same gene, but depending on the inheritance pattern and the type of mutation, the clinical features may differ. So this was a 43-year-old female. So it didn't appear like Stargardt, but we included in the study because father had a phenotype resembling the Stargardt's. So when we did a genetic sequencing, we ended up discovering a totally new gene which was pathogenic. But we are not sure whether this is responsible for this disease, but we are waiting for others also to report the similar conditions. Incidentally, the grandchildren were also carrying the same mutation, but they told they don't have problem. When we examined them, fundus appeared normal, OCT was relatively okay, but autofluorescence did had changes in the macula in the grandchildren's. This is the autofluorescence and the OCT image across 3 generations with increasing severity. So most of the mutation in our cohort had missense mutations. Missense mutation basically means there will be single base pair substitution leading to a totally new amino acids. Among these 8 were novel mutations. We wanted to study the effect of these mutations in cell lines. We did the same by studying the protein expression of ABCA4 gene using Western blot technique. To simplify things for the clinician, the darker the band, better is the protein production, like this V mutation. Same gene, but these are different mutations. We went back and looked at the clinical photographs of this mutation. This is a 13-year-old male with the V type of mutation, had a very mild disease because of better protein production. Whereas second patient, 9-year, that is younger than the first patient, but had more severe disease because he had Q type of mutation. Even the ERG was also telling the same story. The first patient fulfilled was normal. The second patient, though the child is 9-year, he had severe rod cone dysfunction. So how to repair this mutation? So there is a challenge when it comes to gene therapy with a large gene like ABCA4. So we came up with a novel dual vector strategy where we split the gene into 2 halves, which were loaded into the separate viruses, and they were co-infected. Once they reach the target tissue, they combine back and where they are expected to function. These are the micrographs of our initial results in the mouse model. As you can see, as compared to the control, the dual vector take-up is very good. We use beta-galactosidase staining to trace this vector. That means the vectors are reaching where we intend them to reach. So to conclude, I would like to say what was known was Stargardt. This is how a Stargardt looks like, and most commonly caused by ABCA4 homozygous mutation. What this study adds is the genetic sequence and screening of Stargardt cases in Indian family, presence of new genetic and phenotypic variations, and experimental models for the pathogenicity of mutation. And we also had animal models to study the effect of dual vector. All these things, including the patient recruitment, vector production, enzyme, everything was done in India. So So our ongoing projects, we have already produced a mouse model which mimics the human disease. This is one of the ABCA4 knockout gene. As compared to the wild type, there's increased autofluorescence. We injected dual vector and we did ERG. These are all alive mouse. We did ERG 6 weeks later. This was like a wow moment for us. As compared to the control vector and the non-injected vector, you can see the mouse which received dual vector injection had a better amplitude of A and B wave. Like someone was just asking me, like the newly approved Luxturna costs 6.5 crores. How are you going to bring down the cost so that Indian patients can afford? This is the way. So our future plan is to study the epigenetic factors, which is the limitation for this study, and also to start the human gene therapy trial. Thank you so much.
The vector that you injected into the mouse model.
Yes, sir.
What happened to the, how did you monitor the intraocular pressure? What was happening to the optic nerve of the mouse and all that? So how was the titration done for that?
Yes. So first when we inject, it is injected intravitreally. For example, if we inject 10 mouses, not 10 will go into subretinal space. Some will have, as you rightly mentioned, optic nerve damage, retinal extensive hemorrhage, vitreous hemorrhage, and cataract development. Post injection, we did a photograph of the fundus, the photograph and the ERG testing. Those who had a healthy bleb without all this complication which I just mentioned, only those mouses were included for the study.
So the ERG that you did for these mice,
yes, sir.
Was it not dependent on the injection also? Meaning not only the vector, but also on the trauma induced by the injection?
So this was a localized injection, sir. We used Hamilton needle, which is very small. This was a full-filled ERG. The damage which can happen because of the injection, which you rightly mentioned, which is a focal one. Maybe if you do a multifocal ERG over there, it may have changed. But what we did was a full field. We wanted to study the response in the entire, because the gene mutation is present throughout the fundus. So that's why we did full field. Full field may negate the effect of the focal damage which can happen because of the injections.
Fantastic. Thank you.
Thank you.
So by this, we come to the end of the Colonel Rangachari Award, the most prestigious award. On behalf of AIOS and Scientific Committee, we are extremely grateful to our esteemed judges who have been sitting all the while on the stage and, full concentration. And thank you so much for your valuable time. And yeah, please hand over the paper. And first of all, congratulations to all the speakers. Being in Colonel Rangachari itself is great and prestigious, and all the very best to the final result. Thank you.